I wanted to speak to you guys today about uterine septums, and this is something that most people would be unaware that they have. In fact, it would be asymptomatic generally, and often only diagnosed if you'd had some form of imaging, either externally, which is called an HSG, where we take an x-ray while we introduce a dye into the uterus, or where we actually look inside the uterus with a camera, which is called a hysteroscopy. And a septum means basically there's a wall in the middle of the uterus. And the question is, how did it get there? And the answer really is you were made that way. So oddly, when you were in your mother's uterus, your uterus was formed from two parallel tubes. We call them the Mullerian ducts. And so those two tubes fuse to one another. And once they've fused to one another, the wall that they commonly share is then broken down and it's resorbed. So it's broken down from the cervix side all the way towards the top of the uterus. And provided that happens, you end up with a normal uterine cavity. Now, women can end up with abnormalities relating to those two tubes fusing to one another. And if they don't fuse to each other, you can have, in extreme cases, you can have two vaginas, two cervixes, and two uteruses. Or you can have one vagina and two cervixes and two uteruses, which is 5,000 discovery vitality points for a pap smear. Or you can end up with a single cervix and two uterine horns. Those are all related to the tubes actually fusing to one another. Of course, if they fuse, if that wall isn't reabsorbed completely, you can end up with a septum, in other words, an indentation from the inside of the uterus. And that may present with recurrent miscarriage. So if you've had recurrent miscarriages and they find a septum within the uterus, obviously this is likely to be playing a role. And from a fertility point of view, with IVF, if we are going to be placing embryos into the uterus, we need to improve where that embryo is going to be released within the uterus. If we try and avoid touching the septum or the subseptum, then we're going to leave the embryos lower in the uterus, and that's associated with a lower pregnancy rate. So we want to improve that uterine cavity and ensure that we can leave the embryos higher up when we're doing an embryo transfer. So what I want to show you on our screen here is an HSG. This is an X-ray video of a pelvis, and hidden here at the moment is someone's uterus. This little catheter here is placed against the cervix, and as we inject, you're going to see this dye, which appears almost like a dark ink, into the uterus. There it starts to go up the cervix, and you'll notice that this uterus is not a triangle. In actual fact, it looks like a Y shape. So the one tubal opening is in this corner of the uterus, the other tubal opening is in this corner of the uterus. We can see the fallopian tubes on either side, and we see this big dent, and normally there would be a straight line along here. This is a subseptum. I'm going to stop it there, and perhaps I can show you what that looked like when we went into the uterus to fix this. So we've just had a look at that subseptum on the HSG, and I want to show you what that looked like when we looked inside the uterus with a camera. And this is unedited video from this patient's surgery. So what you can see here is that there's a fallopian tube opening on her left-hand side and on the right. And between these two fallopian tubes, there's a very prominent bulging towards us. And that's what is forming that's the subseptum. And what you're going to see is how we cut into this subseptum using a pair of scissors. It sounds ridiculous, but we're doing this underwater because the uterus is normally not distended. We use water under pressure to open it up for us. And when we open and close this pair of scissors, the jaws are probably 2.5 centimeters or 2.5 millimeters from one another. So it looks crazy. It looks like we're using Gardena shears here, but it's actually a very delicate procedure. What you can see here is that there's not a lot of bleeding along this subseptum, and the reason for that is there's not a lot of vascularity in that subseptum. Remember, this is actually a mixture of fibrous and connective tissue. It's not muscle. And ergo the problem with an embryo implanting on this subseptum, because it's not getting a great blood supply. So you can imagine how it might contribute to recurrent pregnancy losses. So you see we're just opening up along the midline. you'll notice the lining of the uterus is sort of a light pinky color, and the subseptum is all sort of a whitish color, almost like scar tissue. And as we open this up, the uterine volume is increasing. So I'm going to skip forward a little bit, and the process remains the same. We're trying to improve this cavity through resecting the subseptum. And after the surgery, the patient's given some estrogen medication, which will promote the growth of the surrounding normal endometrial lining over this exposed area. And essentially, this will allow for an overgrowth of normal endometrium over this exposed tissue and prevent post-operative adhesions. And this is exactly what we found. So I'll just show you this, and this is really towards the end of the procedure. If we just pause that and come forwards a little bit, that's what her uterus looked like after the resection of the septum and before the start of her estrogen therapy. And just to remind you what it looked like before, it looked like that. So I'm going to show you the after surgery HSG, because we always do a pre and a post, and this is basically the post-operative view. And so this is the same patient, and there's the catheter against the cervix, and as we inject, you're going to notice that the uterus has changed shape quite a bit. And we no longer have that Y-shaped uterus. We've got a more normal shaped uterus. We've got a much bigger uterine volume. Volume's probably more than doubled. And this is at the same magnification now as the previous HSG. And so we've really got a normal profile uterus. And this is just one example. We've got multiple examples. But I think just to clear up, if you have been diagnosed with a subseptum and you wanted to know why it needs to be removed, well, one, if you've had recurrent miscarriages, and two, if you're going for IVF, where we're going to transfer an embryo into your uterus, from a technical point of view, as we place that transfer catheter into your uterus, if we were to traumatize the inside of the uterus and bump that septum and cause some bleeding at the time of the transfer, that would obviously reduce the pregnancy percentage chance. And if we leave the embryos lower in the uterus in an attempt to avoid that subseptum, that would also be associated with a lower pregnancy chance. So we want to maximize your chances of being pregnant at every embryo transfer. And that's why we resect that septum and bring your uterus back to a normal shape, so that uterus allows for us to place an embryo as high as possible with the least chance of trauma during the transfer. I hope this has been helpful. If it has been, great. Like it if you like it. And we look forward to giving you more information. Thanks. Bye.